I'm going to present my approach to investigating mediastinal masses. So let's just jump right in here. Now, in the mediastinum, the first thing you want to do is figure out which compartment the mass is located in, or at least centered in. So we have three compartments. Here is the Felsen classification, which is the sort of classical classification that people used to use based on the chest radiograph. But we'll transition here to the ITMIG classification, which is the currently accepted classification scheme, which is based on CT, which is where we're really evaluating our mediastinal masses primarily. So we have three compartments: the anterior or prevascular compartment, which is basically where the thymus or thymic residua is located. So we're anterior to the heart, anterior to the brachiocephalic vein, in what is typically composed of fat here, or is just simply absent in most adults. We have the middle mediastinum or visceral mediastinum, which contains the heart, trachea, esophagus, major vessels, and most lymph nodes. And then we've got the posterior or paravertebral compartment, which begins about a centimeter behind the anterior part of the vertebral bodies and really encompasses the paravertebral location, as the name implies. In other words, along the sides, essentially, of the vertebral bodies. Now, these compartments are not anatomic compartments. They are simply useful for localizing structures and generating a differential diagnosis. There's nothing that prevents a lesion from involving, more than one of these compartments. So let's start with the anterior mediastinum. The anterior mediastinum comprises the majority of mediastinal tumors, and so that's the one you really should pay attention to here. So everyone remembers the 4 T's. But we're really going to focus on of those 3 of those T's, those being the thymoma or thymic epithelial neoplasms, which also include thymic carcinoma, lymphoma, which is called terrible lymphoma in that mnemonic, and then teratoma or germ cell tumors in general. So those are the T's. Now that the T's leaves out the benign lesions, although they also can start with T's. It would be thymic cysts and thymic hyperplasia. So starting with the benign anterior mediastinal lesions, first to talk about thymic cysts. So these are generally low-density oval lesions, typically more common to be straight in the midline in the anterior mediastinum. They can measure greater than simple fluid. In fact, they frequently do, either because of hemorrhage or proteinaceous contents. So if you see something that measures simple fluid, great, you're done. Otherwise, you're going to want to do an MRI to prove that the lesion is pure cystic versus an enhancing solid neoplasm. So this is a thymic cyst. You can see on MRI it is bright on T2, equivalent to that of the CSF. And on this post-contrast sequence, there is no enhancement. So this is a simple thymic cyst. Now, thymic hyperplasia is the other benign entity we see in the anterior mediastinum. Most cases can be definitively characterized by CT. So what you want to look for is generally sort of a triangular or pyramidal shaped structure in the anterior mediastinum. It often has marbled or interspersed internal fat, like you can see in this lesion here. You may see more or less interspersed fat depending on the degree of thymic hyperplasia and the age of the patient. People used to think a lot about patient age when they looked at anterior mediastinal soft tissue and considered thymic hyperplasia versus lymphoma or something like that. But to be honest, with more and more scanning of patients nowadays, we see a lot more older patients who have some degree of residual thymic tissue, and thymic hyperplasia is also not at all uncommon in the oncology patient population, where you get rebound hyperplasia after ceasing chemotherapy. So I wouldn't really use the age of the patient to make my determination. I think the real key here is morphology and the presence of interspersed fat. Now, if you see something that looks more bulky, looks more mass-like, and you don't see the internal fat, then you can do an MRI. And the key sequence you want to look at are the in and opposed phase or chemical shift imaging. Here we can see the in phase and the opposed phase, which you can tell based on the India ink artifact here. And we've got, here's the same case with the anterior mediastinal soft tissue, substantial signal dropout on the opposed phase image, demonstrating that there's intravoxal fat, and this is diagnostic of thymic hyperplasia. Now, there are some cases, like in this case, where the signal dropout is not quite as striking visually. If you have visual signal dropout, then you're done. You don't necessarily have to measure anything. On the other hand, if the dropout is not as striking, then you can go ahead and measure what's called the signal intensity index. And so this you measure, you have to use what's called a dual echo sequence. In other words, the chemical shift sequence needs to be acquired such that the in and opposed phase images are acquired simultaneously as part of one sequence. That's the standard in most scanners nowadays. So in that setting, you want to go to the exact same slice in both image sets and try to measure essentially the exact same ROI. And you get the signal intensity, obviously not Hounsfield units, but signal intensity numbers in both of these. And it's a simple formula of subtracting the signal intensity in phase minus opposed phase divided by in phase. And then, of course, you multiply by 100 to get the percentage. If the signal dropout is greater than, let's say, 9%, then you conclude that it's thymic hyperplasia. And if the signal dropout is less than 9%, then you really want to think about thymoma or lymphoma or some other neoplastic process. Now, again, I didn't put an example in here, but this is not 100% accurate. And in particular, if we've seen in young female patients that they may have thymic hyperplasia with essentially no intravoxal fat. And I would say that's also going to be the case in the pediatric age group, where you're really not going to see intravoxal fat, even on MR, in many cases. And so in those situations, you really have to use a combination of judgment, morphology, and clinical scenario to help you out. And one thing that can be very helpful is to get a follow-up MRI in several months. Hopefully you can wait as long as 6 months or a year. And you'd expect to see, and generally we do see, that these tend to involute over time with decrease in size and increasing interspersed fat within the lesion over time. However, as I said, just be careful in young women where the lesion may not have the intravoxal fat. But in general, this is a pretty good formula to use. And the reference here for this particular formula is Priola et al. It was published in Radiology in 2015. So now jumping to the neoplastic lesions in the anterior mediastinum, we've got the thymic epithelial neoplasm, so that's really thymomas and thymic carcinomas. These are generally seen in older patients. So in a paper that we published, we saw it was almost exclusively seen in patients older than 35 years. These lesions tend to have lobulated margins and are frequently located off midline. In other words, they're in the anterior mediastinum, but they tend to project off of center. These may be invasive, particularly invasion of mediastinal fat and invasion of the pericardium. You can also see pleural metastases, so-called drop metastases, as the lesion invades into the pleural space, and then small tumor deposits sort of fall often dependently and inferiorly within the pleural space. So it's important in these cases, if you have a thymoma or something you think is probably a thymoma, that you closely inspect the pleural surfaces to look for metastases. Now, the next important entity is lymphoma. Generally seen in I should say it's more common in the younger age group, but we absolutely see lymphomas in older age patients. But in the older age groups, the thymoma and thymic carcinoma are far more common. So that often leads to differential. Regardless, lymphomas tend to be pretty aggressive neoplasms. They will invade and displace other structures. There's often associated lymphadenopathy, and in particular, you want to look for the presence of internal mammary lymphadenopathy. Here we can see the right internal mammary artery, and here is a lymph node adjacent to it. And the study that we published, internal mammary lymphadenopathy had the greatest predictive value for making the diagnosis of lymphoma. So that's something you should really look for if you have an aggressive anterior mediastinal mass. It can really help you make the diagnosis. Lymphomas, as I mentioned, can invade mediastinal structures. In this case, it's invading and compressing the left brachiocephalic vein. May also directly invade into the lung parenchyma. And germ cell tumors. Now, I showed an example of a germ cell tumor with macroscopic fat earlier, and I'll show another one in just a second, but they do not all have interlesional fat. In particular, the malignant germ cell tumors may not have it, particularly the dysgerminoma or seminoma histology will not have interspersed or intralesional fat. So this is a case of that. Germ cell tumors are almost exclusively seen in young patients, and malignant germ cell tumors are almost exclusively seen in male patients. It's otherwise difficult to distinguish a lesion such as this one from lymphoma. But if you do see, like in this case, intralesional fat and calcifications, then you can be pretty confident that the lesion is some sort of germ cell tumor. If you see fat, calcification, and fluid without substantial soft tissue components, then it's probably benign. If there are substantial soft tissue components, then it's probably malignant. But regardless, these lesions end up undergoing resection. Now, a few other sort of imaging features to look for that might help you with your differential. So cystic lesions in the anterior mediastinum, we've covered all these lesions, but just to point out, thymomas can often be cystic, or it's really they're necrotic, and they can even be predominantly or nearly completely necrotic and cystic appearing, such as in this case here. Of course, we mentioned the thymic cyst in the anterior mediastinum, which is of course purely cystic, and then many germ cell tumors have a large cystic component like this one here, although it also has a mural solid component, but they can also be purely or nearly purely cystic. In the context of a cystic anterior mediastinal lesion, really MRI is your best friend, and so you can do post-contrast imaging with subtraction and demonstrate here that this necrotic thymoma had nodular, mural, and septal enhancement. This thymic cyst, you can't even see it at all. There's no enhancement at all. And then this lesion, which was a malignant germ cell tumor, has a substantial nodular enhancing component in addition to the cystic component here. More rarely, but something to be aware of, are other cystic lesions. So here is the multilocular thymic cyst, which basically is a proliferation of lymphoepithelial cysts within the thymus. It's analogous to what you can see in the salivary glands in patients with HIV or Sjogren's syndrome, but you can see it in the thymus as well, again in the same patient population. And it's just composed of numerous small cysts with intervening normal enhancing septations. Typically, you won't see nodular enhancement in these lesions. So if you see something that looks like this, you can suggest the diagnosis of multilocular thymic cyst. These will often go to resection just to prove that that's what they are, but they are benign. This was a case of a spontaneous hematoma in the anterior mediastinum. Hard to know if there was an pre-existing cystic lesion that bled, or if this is just a spontaneous hematoma without an pre-existing lesion. But regardless, this lesion did not have any enhancement, and so you can easily conclude that it's benign. Sometimes in the setting of hemorrhage, you will see some thin mural enhancement around the lesion, and those you'll have to follow to prove that they're benign. Another important point to note is that thymomas, as I mentioned earlier, can be very cystic and very necrotic, and sometimes their enhancement is only seen very late. So we can see here this solid appearing anterior mediastinal mass with sort of T2 intermediate signal. On the first post-contrast phase, there's not very much convincing enhancement here. There is some signal here. Hard to know if it's misregistration artifact. But on a second coronal post-contrast image, you can see very convincing enhancement in this lesion. And so this was indeed a thymoma. So it's important to do some delayed phase imaging if you're doing MRI for anterior mediastinal masses, just to make sure that they're not enhancing late. Here's an example of some simple cysts that have proteinaceous content, and so they have intermediate signal on T2 weighted images and bright signal on the T1 weighted images, but there's absolutely no enhancement, and these are actually surgically proven to represent cysts. So, as I mentioned earlier, thymic cysts tend to have proteinaceous or hemorrhagic contents, and so they tend to measure greater than simple fluid on CT, and they will also demonstrate signal characteristics of proteinaceous content on MRI. So really, subtractions are very helpful in these lesions if they have bright T1 signal on pre-contrast imaging. So I just made a little table here kind of summarizing what I said. And so, most of the time you'll be able to conclude pretty easily that the lesion is a cyst because it'll be T2 bright without enhancement, or that it'll be a thymoma because it'll have nodular or, extensive enhancement within it. Or even if you see rim enhancement, if the lesion doesn't have nice fluid signal on T2 weighted images, then you really want to think about a thymoma. But there are cases where you do not have fluid signal on MRI, so you have a T2 intermediate lesion, but without enhancement. This is the case where you can't really be 100% sure that it's simply a proteinaceous cyst, and so we recommend following those lesions. And similarly, T2 hyperintense, so fluid signal lesion, but with some rim or thin septal enhancement. Those are also kind of indeterminate. Probably it's just a complicated cyst. Sometimes they can get infected and have hemorrhage and have a little bit of enhancement associated with those. So those, again, you probably want to follow. All right, moving on to the middle mediastinum. So middle mediastinum is the bulk of where your lymphadenopathy is. So metastatic disease obviously represents a large fraction of these cases, and so we're not really going to talk much more about that. Those are usually self-evident cases. So we'll talk about several other lesions. The middle mediastinum is kind of your grab bag with multiple different kinds of lesions there, and so it's the hardest one to really generate a differential. But we'll go through a few imaging features that can help you generate a differential diagnosis. So the first one are cystic lesions. You've got a cystic lesion in the middle mediastinum. The first thing you want to think about is a duplication cyst, foregut duplication cyst, which could either be tracheal or esophageal in origin, but it doesn't really matter. These are typically located adjacent to the trachea, mainstem bronchi, or esophagus. This lesion is kind of adjacent to both a bronchus and the esophagus, kind of lobulated, nicely T2 bright lesion here. They tend to be low attenuation on CT, but again, if infected, proteinaceous content, hemorrhage, etc., they may measure greater than simple fluid. So MRI is really helpful for these lesions, and they may have a little bit of rim enhancement if they're super infected. Usually the middle mediastinal cysts are not a difficult diagnosis to make with MRI. But on CT, they can be occasionally confused with subcarinal lymphadenopathy. Here's another example of a duplication cyst adjacent to the esophagus. This lesion is sort of intermediate soft tissue attenuation on CT, but is fluid attenuation on MRI and did not have any enhancement. The other thing you can consider in the middle mediastinum as far as cystic lesions is a lymphangioma. These, as opposed to the duplication cysts, which tend to be sort of oval in shape, the lymphangiomas tend to kind of insinuate within different compartments, but regardless, they are benign. Now, if you encounter a hypervascular lesion in the middle mediastinum, you've got an interesting differential diagnosis. So, four main things to think about. One is intrathoracic extension of a thyroid goiter. Now, we didn't mention this earlier, but in the 4 T's that are often mentioned for anterior mediastinum, one of those is thyroid. Now, the thyroid can extend to the anterior mediastinum, but it's quite rare. And far, far more commonly, when you get intrathoracic extension of the thyroid, it extends into the middle mediastinum adjacent to the trachea, like in this case here. These are usually self-evident because of direct extension from the thyroid, but that's not the case 100% of the time. Usually you can tell, though, by the morphology of the lesion if it looks like thyroid. Metastatic disease from hypervascular tumors, most notably renal cell carcinoma, tends to do this and give you extensive mediastinal lymphadenopathy that's hyperenhancing. The third thing to consider is paraganglioma. This is quite a large lesion in this case. They're very hypervascular. They often recruit a lot of collateral vessels. Typically, these are seen adjacent to the aorta, particularly adjacent to the ascending aorta, like in this case. You can also see them sometimes in paraspinal locations. And then the fourth lesion, which I'm going to go back to the slide here, is Castlemans disease. This is a benign proliferation of lymphoid cells. Most commonly, it's so-called unicentric Castlemans. In other words, it's a single lymph node that becomes enlarged and is hypervascular. There's also an entity known as multicentric Castlemans, which is almost exclusively seen in HIV patients. Regardless, it gives similar imaging characteristics, which is simply hypervascular lymph nodes. So if you have a single hypervascular lymph node or even multiple hypervascular lymph nodes and without a known malignancy, then you want to consider Castlemans. I also mentioned parathyroid adenoma here. They're usually quite small and often difficult to see on standard CT imaging, but they would be hypervascular if you do see them. Okay, shifting gears to the posterior mediastinum. Like the anterior mediastinum, the posterior mediastinum has a relatively short differential, in fact, much shorter even than the anterior mediastinum. And really, the primary thing to think about here are neurogenic lesions. In fact, all three of the examples I'm showing here are neurogenic lesions. We'll get to a few other entities in just a moment. This is an example of a schwannoma here. This is a ganglioneuroma, and we've got a lateral meningocele. Really, the best way to evaluate lesions in the posterior mediastinum, particularly if you think they're neurogenic, is to get an MRI, because often neurogenic tumors are very hypodense on CT, but you'll be able to see the enhancement, if there is any, with the MRI. So neurosheath tumors are by far the most common, in particular schwannomas, by far the most common neoplasm that we see in the posterior mediastinum. They often arise from the neural foramina, although they can also arise from the sympathetic or parasympathetic ganglia. The other lesions that we can see, sorry, I didn't put examples here, but we have an example here of a ganglioneuroma. These tend to arise from the ganglia and tend to be seen in younger patients. And then you can also see paragangliomas, as I had mentioned earlier, in the posterior mediastinal paraspinal location, again arising from these thoracic ganglia. The lesions that arise from ganglia tend to be longer in the craniocaudal dimension, whereas lesions that tend to arise from the neural foramina tend to appear along one inner space, or extend essentially horizontally rather than vertically. I put in this table of distinguishing neurofibromas from schwannomas. To be honest, these imaging features are not all that helpful, and schwannomas are far more common unless you have a known diagnosis of neurofibromatosis. And again, the distinction is not important. These lesions almost always go to surgical resection anyway. The only thing to be aware of is that schwannomas can have FDG uptake, and that does not imply anything malignant about them. You can have, obviously, osseous lesions. This is an example of an osteochondroma. We can also see paraspinal abscesses in this location. And obviously, like metastatic disease, can extend from a vertebral body or a rib into the posterior mediastinum. Now, two other entities. Everyone loves showing examples of extramedullary hematopoiesis. Here's an example. This occurs in patients with an underlying hematologic abnormality, most commonly sickle cell and or thalassemia. You may see pure soft tissue lesions, or like in this case, lesions that are comprised of both fat and soft tissue components. They're typically bilateral, although they may be asymmetric. And usually the clinical history and the bilaterality can help you make the diagnosis. Hematologic malignancies often also involve the paravertebral locations without having a discrete osseous lesion. This is an example of myeloid sarcoma, essentially extraosseous extension of the patient's AML into the paravertebral location. So in summary, we talked about a number of mediastinal lesions, and I'll just summarize some important imaging features to look for and help you make your differential diagnosis. So in the anterior mediastinum, the benign lesions tend to be either oval, which would be the thymic cyst, or triangular shape, which would be thymic hyperplasia. Thymomas tend to be lobulated. If you see the presence of interlesional fat, it could be thymic hyperplasia, or if it's macroscopic large globules of fat, then it's probably a germ cell tumor. Invasive lesions, you really want to think about lymphoma, malignant germ cell tumors, and thymic carcinoma. And if you see a cystic lesion, you really want to do an MRI to help further evaluate that and look for enhancing components. In the middle mediastinum, lymphadenopathy is obviously very common. Another thing to think about is duplication cysts, and if it does not measure simple fluid, then MRI is, again, going to be very helpful there. Your hypervascular lesions, metastatic disease, paragangliomas, Castlemans, and of course, thyroid extension. And then in the posterior mediastinum, it's almost always going to be neurogenic tumors, and MRI can really help you sort that out and help with pre-surgical planning. All right, I hope that was helpful. Thanks.